Hello everyone, welcome to Hematology and Coagulation. Today we're going to discuss hematopoiesis, heme, H-E-M-A, blood. Poiesis is making of blood. That's just a loose definition of it. All right, hematopoiesis. Officially, hematopoiesis is the production, development, differentiation, and maturation of all types of blood cells. Red blood cells, white blood cells, platelets. So it's everything, every blood cell that is made in your body. Together, that term for the process of making blood cells is called hematopoiesis. Hematopoiesis occurs in two different ways, primarily. One is extramedullary hematopoiesis. Extra meaning it actually means outside of the medullary process. So this is outside of the bone marrow. And then there's hematosplenomegaly, which is enlargement of the liver and spleen. So that is an indicator that hematopoiesis is occurring outside of the bone marrow. We'll get into some of this in great detail later, but for an adult, hematopoiesis occurs outside the bone marrow when there's issues. And we'll discuss what those issues are. Normally, we should have all of our blood cells being made from the bone marrow. That is different from when you're a newborn baby. The next type of hematopoiesis is intramedullary. Intra mean inside of the bone marrow. Most hematopoiesis occurs here. Okay, so that's what we're looking for. In the beginning of life, when the fetus is development, hematopoiesis does not occur in the bone marrow. The bone marrow is not really formed as appropriately as it needs to be. Therefore, hematopoiesis has to take place somewhere else. And the places that it occurs is the yolk sac, spleen and liver, the thymus, lymph nodes, and of course the spleen. So if you look at this, you see that there's some time frames. In the beginning, yolk sac, 2 weeks to 2 months. Then the spleen starts to take over around that 2-month time, the spleen and the liver to 7 months. And then the thymus and lymph nodes and spleens go from 7 months to birth. You see how the liver is kind of important here, but in that early stages of life, and the spleen is kind of important. And that speaks to some of the job that the spleen and liver actually have later on in life with sequestering things that are not good for your body and ridding your body of those disease elements or those deformed elements. So those two organs are incredibly important. Late fetal development to adult life, what happens? The bone marrow takes over the job of hematopoiesis. Notice the spleen, the thymus, and the lymph nodes are secondary, tertiary. They are other places where hematopoiesis can take place. And when we get into coagulation, this is going to become really important when we talk about what happens when a patient has like a splenectomy, when the spleen is removed, and how that impacts their red blood cells and their white blood cells and how many they have. So the bone marrow does most of the work, but it doesn't do all of the work. Okay, so the basic thing that you need to know is all cells start from one main cell. That main cell then goes and becomes this set, which is the common myeloid progenitor cell or the common lymphoid progenitor cell. Within the common myeloid, there's granulocytes, which are neutrophils, and these granulocytes are basically white blood cells, right? And then there's erythrocytes, which are basically red blood cells. Monocyte is also a white blood cell. And megakaryocyte, which are your platelets. Okay, so they all come from the myeloid stem cell over here. Then on the other side, you have your lymphoid, which are your T lymphocytes, which they are white blood cells. your natural killer cells, and your B lymphocytes, which are again white blood cells. Later on, you will learn that this group has an important role in fighting off infections. And I point this out because most of the time, people don't think of these groups as being able to fight infections. And they don't, when people are learning, they're like, oh, well, what about the neutrophils? What about the lymphs? Those are really important. Well, within the lymphs, these are T lymphocytes and B lymphocytes and natural killer cells. They just don't get the understanding that these are lymphocytes and how important they are to get in the body to be able to fight off disease states. So we're going to eventually learn about that in this course. Not in as much details as one would expect, because this is, of course, the MLT course, but you would definitely know at the end of the course more about the T lymphocytes, the B lymphocytes, natural killer cells, and infectious process. So, what do you need to know about the spleen? Spleen, 4 functions. Filtration, and it's a reservoir, which means it stores things, and it has a function in immunity, and then of course there's a function in making cells. Filtration, it looks at red blood cells, platelets, and if there's anything normal, it gets rid of it. We call that sequestering. So inclusions are pitted from the red blood cells without destroying their cellular integrity, and then those inclusions are gotten rid of. It's a reservoir for storage, which means it has 1/3 of the circulating mass of platelets and 1/3 of the granulocyte mass. This is actually important. And it's important from an understanding of building a foundation so that you will have the knowledge to know what happens when patients lose the spleen. Later on, this is going to become extremely important when you're understanding disease states. Okay, the spleen also is capable of causing platelets to move into the peripheral circulation, which is important to stop bleeding. Its role in immunology, it is the largest secondary lymphoid organ. Now, you might want to know, well, will I actually be tested on this? No, not necessarily. But you will be tested on the specific diseases, and in a disease, it would say, oh, patient had a splenectomy or something to that effect. And then you need to know what that splenectomy means. So you have to know if the spleen is not there, which the splenectomy is the removal of the spleen, then what could go wrong? Well, for one, it doesn't filter out the bad red blood cells and the bad platelets. It doesn't, now we don't have all of those platelets and granulocytes that are in the spleen. So everything that the spleen does can stop, right? So then that's going to have another impact on the patient. Increased bleeding that can occur. So you just have to know that. Okay, it also promotes phagocytic activity, which is, we're going to learn about that. That's the process of bacteria being engulfed and eaten. So it's very important for you to get rid of bacteria. Hematopoietic role, meaning making cells. And you saw it had a huge role in the early part of life. Previous slide told you that. It still has a part of that in later stages of life, depending on if the patient is a normal patient with normal functioning versus if a patient has some type of disease state and the spleen has to compensate for the bone marrow not being able to do as much of the work. That's the beautiful thing about our body, is that there's a lot of systems built into place to allow us to still maintain bodily functions even when one part of the system is not working at its optimal. Generally, this is just information. Where's the spleen? Left side of the body below the ribs. So that's kind of important, because if you want to know of a case study that a person receives and they say they have pain in left side of the body, then you think, oh, maybe something's wrong with their spleen. There's different things within the spleen. There's red pulp, which is what indicates red blood cell filtration. There's white pulp, which is lymphocyte processing white blood cells. Then there's called a marginal zone. That is where the storage of lymphocytes and platelets occur. Here we go. Splenectomy. Why would a person have a splenectomy? Well, maybe due to damage to the organ, because the spleen is sequestering cells like platelets, resulting in low counts and potential bleed. Okay, so maybe the spleen is doing too much. Maybe the spleen is working overboard, and then they decide that the spleen has to come out of the body. What are the risks of having a splenectomy done? Well, there's a lot of infections that occur in patients once they have a splenectomy. There's a lot of encapsulated bacteria that also end up in the body. And of course, if the body cannot fight off the bacteria, fight off infections, viruses, and things, then of course the patient could ultimately die. If necessary, leave small tissue nodules behind. So the thought is that if you leave little parts of the spleen behind and take the majority of the spleen out, that you will not have as many of the issues occurring, because there's some of the nodules there, which in essence may be doing some of the work, kind of like compensating for the fact that you remove the spleen. What happens when you have a splenectomy? Abnormal red blood cells can be present. White blood cells and platelets have to find storage elsewhere. Normally there's not really any place else for them to go. And encapsulated bacteria present serious illnesses, can even lead to death. So splenectomy is not necessarily something that one must have and for every occasion. If someone's going to have a splenectomy, then there's a problem. So let's get into the bone marrow, which is the main site of hematopoiesis. What's the function of the bone marrow? It's the main factory for making all adult red blood cells, white blood cells, platelets. It's responsible for cell maturation. That stem cell that is a few slides ago I mentioned, well, that stem cell is like a baby. And it's like that cell then breaks off and becomes all these other things, a white blood cell, a red blood cell. And then there's stages that occur before that baby red blood cell becomes a mature red blood cell. And the mature red blood cell has all the functionality to deliver oxygen to the body. The baby red blood cell does not have as much functionality. The bone marrow is responsible for that cell maturation. Bone marrow responds to anemia. So if a patient is anemia, which you will learn more about what that is, but that's a low hemoglobin, right? That's like the patient's anemic. They have a hemoglobin of 6. Anemia occurs because they're like bleeding out, or they have some type of disorder that's causing them to be anemic. The bone marrow will respond to try to eliminate or mitigate the anemia. And what the bone marrow does is produce more red blood cells. Erythrocytes is red blood cells. Same thing, if there's an infection that occurs in the body, the bone marrow says, oh, we need more white blood cells, leukocytes. So the bone marrow will produce more white blood cells. And then if a person is bleeding out, maybe a person had a limb cut off, maybe something to that nature, and they were bleeding out. The bone marrow says, wait, we have to stop the bleed, so we're going to produce more platelets, and platelets are also known as thrombocytes. So the bone marrow is extremely important, right? The bone marrow is making sure that you actually can survive, because if you don't have red blood cells, white blood cells, and platelets, you will not survive. Bone marrow is considered the largest organ of the body. One of them, the skin, is actually the largest. There's yellow and red marrow within the bone marrow, and then it has a lot of nutrients. If a person is under the age of 18, the marrow is spread in major bones, and then if the person is greater than 18, the marrow is mainly located in the iliac crest and the sternum. This is important because of a bone marrow procedure of where it is that a doctor would go to try to receive marrow to help diagnose the patient's disorder. What is red marrow? So red marrow is what's called hematopoietically active. All right, so this is located in bones in early fetal and childhood development, and then it is not as common when you become an adult. Adults have red marrow, but they are in the proximal ends of the long bones, the sternum, the skull, the scapula, the ribs, and the pelvis. And then they have about equal amounts of red and yellow marrow. Yellow marrow is hematopoietically inactive marrow, which is primarily the fat cells. Which fat is very important, so don't think, oh, it's inactive. Well, that's just meaning that it's not producing red blood cells, white blood cells, and platelets as much. But fat cells are incredibly important, and the yellow marrow contains the fat cell, which is also why fat is yellow. What does the bone marrow contain? Erythrocytes, leukocytes, thrombocytes. Other cells and elements, osteoclast, fatty tissue, and stroma. Right now, what do you need to know about that? You need to know what is in the bone marrow, because you may have a question about what is in the bone marrow. You need to know what happens if a person has a problem with their bone marrow. Well, perhaps if the bone marrow is not functioning, you can have two things happen. One, the bone marrow cannot produce enough erythrocytes, leukocytes, thrombocytes. So then you can have bleeding, you can have increased infections, or the bone marrow can produce a lot of erythrocytes, leukocytes, and thrombocytes, but they could be not functioning correctly, and you still have bleeding, infections, ultimately death. So you kind of have to know that. All right, so define a nucleated red blood cell. A nucleated red blood cell is an immature red blood cell. That means the bone marrow has put it out early. So that's the other side of the coin, where the bone marrow has produced too many red blood cells, and it's producing them so fast, it's spitting them out into circulation before they are mature enough to handle the job of a red blood cell. So that's just what nucleated red blood cells is. All right, let's discuss some changes from the bone marrow. There's a myeloid to erythroid ratio. The myeloid are those cells that were on the left side of the chart, excluding the erythroid. Myeloid, just talking about the white blood cell side of it. This ratio can predict hematological problems, meaning if a person has an issue with producing blood cells. The normal ME ratio is 3:1 to 4:1, meaning you should have 3 times the myeloid cells that you have as erythroid cells. And for this purpose, we're going to say myeloid cells being your neutrophils, your eosinophils, and your basophils. It's just cells within that range. And the erythroid, we're going to say, are your red blood cells, because that's what it means. Erythroid hyperplasia, meaning increased production of red blood cells, is going to cause your ME ratio to decrease, because that means that the number on the right hand side of the equation is going to go up. So instead of it being 3:1, maybe it's like a 3:2, right? So this myeloid erythroid ratio has increased. Anemia causes the body to produce erythropoietin. Erythropoietin, it causes the body to have increased counts of red blood cells. So that's what causes this to go up. So if a patient is anemic, the body is going to respond, meaning the bone marrow is going to respond and make more red blood cells. It is going to make more red blood cells because erythropoietin told it to. The body produces erythropoietin, and then there you go. It started manufacturing all of these red blood cells. The problem is that there's now an increased amount of immature red blood cells. Those immature red blood cells are called nucleated red blood cells. And that's because they contain a nucleus inside of the red blood cells. So another thing that can happen is reticulocytes can be seen, and then polychromasia. Polychromasia means the change in color. So there's going to be more color, a bluish kind of color in your slide. So you're going to be like looking at all these immature cells. The color of the slide is going to be different. So if a patient presents with anemia, one can expect that a case study would reveal nucleated red blood cells, increased reticulocytes, and polychromasia. And that would be one way that you know if you were given a choice of the case study gave you the patient presented, myeloid urethral ratio was 3:2. CBC differential found done on CBC indicated nucleated red blood cells, increased reticulocytes. What disorder do you have? And they gave you choices like IDA, which is immune deficiency anemia, or I'm sorry, which is iron deficiency anemia, or they gave you something like multiple myeloma, which is not an anemia, or if they gave you one of the other cancers that a person can have, leukemia, which is decrease in the white blood cells. Again, it's not necessarily a anemia, although it's similar. But the presence of those nucleated red blood cells would tell you that it's probably going to be the iron deficiency anemia. So this information is going to be really helpful to show you how to figure out what's happening in the case study. And that's why you need to know some of this background information. Although you probably won't have a specific question that says, well, the myeloid urethroid ratio is what? It's not going to be a question that really asks you to know that it's 3.1 to 4.1. It's going to be a question that pretty much gives you a myeloid urethroid ratio of 4 to 5 or something like that. And then you're going to know that there's a shift. Let's talk a little bit about stem cells. Stem cells are the multi-potential cells that we talked about from the beginning, and they develop into non-lymphoid or lymphoid cells. Lymphoid cells are the T cells and the B cells. Non-lymphoid cells are the white blood cells, which include neutrophils, basophils, eosinophils. The red blood cells are included as a non-lymphoid, and the megakaryocyte family is included as a non-lymphoid. CFU means colony forming units, and GEM is this germane stem cell line. So the germane stem cell line for megakaryocyte is that GEM, and that's not really as important. What is important is colony forming units, because you're going to see that in micro if you haven't already taken it, and it's going to come up a couple of different times. Okay, with the lymphoid cells, you have T cells, which are responsible for cellular immunity, which means cell-to-cell communication and helping to provide immunity in the body. The B cells are responsible for humoral immunity. This means they're circulating antibodies directed by plasma cells, which plasma cells are B cells. Cytokines. Cytokines are chemical signals that are responsible for promoting a specific line of cell, and they control replication and clonal or lineage selection. Where in essence, they are responsible for the maturation and growth and inhibition of stem cells. So they keep the balance. You have erythropoietic red blood cells, you have interleukins, and you have colony stimulating factors. Um, this is going to come together. This is the beginning part of learning about this, but it's going to make more sense for you as we go further into the program. All right, so erythropoietin is a hormone cytokine produced by the kidneys that function as a targeted erythroid growth factor. So there you have it. Erythropoietin is the hormone released once the body is like in anemic state, and then it's released by what? The kidneys. So of course, if you have problems with your kidneys, you're not going to be able to produce the erythropoietin, right? So it's kind of important for you to understand where this hormone is produced, and therefore certain disease states, things that could come about as a result of those disease states. All right, so then this erythropoietin causes red blood cell growth factor. So erythropoietin balances out the red blood cell production. So the body can produce a lot of it if there's not enough red blood cells being produced, and then it can produce just a little bit of it if you have enough red blood cells available. It is available as a pharmaceutical product, and this is just a side thing that if you're working with cancer patients or those with renal disease, they sometimes have to receive erythropoietin to maintain their red blood cell level. And if you have a patient taking human recombinant erythropoietin, in the laboratory, we will see an increase in what? Immature red blood cells, just like if they were anemic. So they could come in and get that shot, and we would see like anemia, nucleated red blood cells, increase in reticulocytes, polychromasia on a slide. The next thing that we're going to talk about is the bone marrow procedure. It's a very invasive procedure, so the question becomes, why would anybody have it done? It is done when a physician is unable to determine either disease progression or treatment progression. And so it's not something that's done often. Most of the time, if someone's having it done, they're traditionally a cancer patient. As technologists and technicians, you act as an assistant in this process, which means the doctor's going to do the procedure, but you're going to collect the sample and put it on the slides and look for spicules to make sure it's the appropriate sample so that then the physician can review it, or whomever reviews it. It's either the pathologist is going to review it or a hematologist is going to review it. All right, so the best choice is the iliac crest. They pretty much put anesthesia on the site, and then blood comes out, and a biopsy is collected. And then the technologist looks for the spicules from the specimen, which the spicules are the areas that in the sample that are richest with cells, and this will be so helpful. So what I have done is included a bone marrow sampling handling video for you, right? You can always Google bone marrow procedures if you want to, but this is extremely important to help you understand what's happening once a bone marrow is collected. If you cannot click on the link because you're watching this as the video, then just write down this information. If not, you should have the PowerPoints, and then you should be able to click on the link in the PowerPoint. All right, so once you've collected the bone marrow, you get a report. This report is going to have the ME ratio, right? So that's going to be very important. The maturation of each cell line, so they're going to tell you, hey, how are we seeing white blood cells? Are we seeing red blood cells? Are they mature? Are they immature? The marrow to fat ratio, presence of abnormal or tumor cells. All right, so that's all done using a right Gamma stain. This is not something that you as a technologist would report. Again, it is a physician who reported. Sometimes a physician wants to have a Persian blue stain done, and that is going to allow them to see how much iron is actually there and check whether or not the iron is adequate. All right, so now we're going to move on to the CBC, complete blood count. It's kind of important for you to know this. You have to know what is included in a CBC. So that's the white blood cell, red blood cell, hemoglobin, hematocrit, mean corpuscular volume. Corpuscular is like cellular volume. Mean corpuscular hemoglobin, mean corpuscular hemoglobin content, the platelet count, and the red cell distribution width. And then we're going to learn what all of that is. The sample is required EDTA, that's a purple top 2, ethylene ditriamine acetyl is a long word, but anyway, it's EDTA is the anticoagulant that is used. You read the sample off of an instrument. Most of the time nowadays, you take the purple top, collect it, put it on an analyzer. After you rotate it, you got to mix it. The instrument's going to tell you what the white blood cell and all that stuff is. We even have instruments now that will do a differential, so they'll make a a smear and look at it and tell you what the white blood cells actually look like on the slide and things of that nature. And every once in a while, you actually have to go back, depending on where you work, and do a manual differential. That's neither here or there, because when you have your exam, you're going to have to know the principle of doing a manual differential, and you're going to have to know what you're going to see. So you're going to have to know like what a red blood cell looks like, what a white blood cell looks like, and you actually have pictures on your exam. You may only have 5 pictures, but you will have pictures on your exam, and depends on what type of exam you take as to how many pictures you have. So white blood cell, red blood cell, hemoglobin, MCV are directly read. Another thing that you have to know is what is directly read versus what is calculated. Hematocrit is calculated. Okay, so white blood cell, red blood cell, hemoglobin, and MCV are direct. Hematocrit is calculated. And then there's correlation checks. And these correlation checks are done between the red blood cell indices to make sure that they make sense. And then there's another type of correlation check, delta checks, meaning the previous result that a patient had, make sure that the current result is kind of consistent with the previous result. So there's different correlation checks that occur. Significant part of quality assurance is when you run the CBC, the rule of 3 must be implied. So this means that the hemoglobin times 3 is going to be equivalent to the hematocrit plus or minus 3. Or the red blood cell times 3 is going to equal the hemoglobin. Meaning, if you get a red blood cell count of 5, you multiply it times 3, your hemoglobin should be 15. And then you multiply 15 times 3 is 45, which means your hematocrit should be between 42 and 48. If those numbers match up, then you're going to say that your sample was overall a legitimate sample, meaning it wasn't diluted with saline or anything like that to throw it off. It wasn't a sample wasn't had enough specimen in it, because then if it was QNS, then your correlation checks would fail as well. All right, you will have to know the rule of 3. You will have to know how to calculate the hemoglobin hematocrit. And then you have to know about automated instruments. Automated instruments are going to give you a picture of the data, and it's going to be on a histogram or a scatter plot. Most machines also offer automated reticulocyte counts now. Pretty much all of them do. But you still have to know what the reticulocyte count is, the reference ranges, and everything. Alrighty, so I mentioned anemia. So what is it by now? You should know what it is. Decrease in oxygen carrying capacity. And it is a decrease in oxygen carrying capacity because there's a decrease in red blood cells or a decrease in the quality of red blood cells. There are 3 morphological classifications of anemia. First one being normochromic, normocytic anemia. Normo, N-O-R-M-O. This portion of the word means normal. Chromic means color. And then we have normocytic, meaning normal. And we have this part meaning cells. So this is a red blood cell that when you look at it when you look at your slide, this red blood cell is going to have the normal color, the normal cell shape, and then yet it's going to be in anemic state for the patient. The MCV is very important in determining states of anemia. The MCV is going to be between 80 and 100 femtoliters, and the MCHC is going to be between 31 and 36%. Yes, you need to know this. 80 to 100 is pretty standard. MCHC 31 to 36, sometimes you can see it as 32 to 37, but you need to know that approximate range. Next type of anemia you have is microcytic hypochromic anemia. Again, micro meaning small cells, hypo meaning low color anemia. In this case, our MCV is less than 80, so it is low. Our MCHC is less than 30%. So the cells are small and they lack hemoglobin. Eventually, I'm going to show you some slides and you'll be able to hopefully recognize what microcytic looks like. So the first thing we had was normocytic, normochromic. MCV for normocytic between 80 and 100. And MCHC for normocytic between 31 to 36 or 32 to 37. But pay attention to the fact that the indices that are determining whether or not a patient is anemic are your MCV and your MCHC, what type of anemia they have at least, right? So you're going to look for these on your exam and you're going to immediately say, okay, if it's less than 80, if it's low, I'm going to say microcytic, which is going to be small cells and they lack hemoglobin, hypochromic. And then we have our third primary category, which is macrocytic. Now macro means big or large cell, normochromic, normal color anemia. In this case, our MCV is greater than 100. All right, so the cells are large and may be oval. Hemoglobin is normal. Notice it did not give you an MCHC. The MCHC is the normal portion of it. So the MCHC is probably going to be normal. Right, so here we go. The MCV greater than 100 is a macrocytic. Large cells may be oval in nature. Hemoglobin appears normal. Red blood cell indices are MCV, MCH, MCHC. Mean corpuscular value, MCV. Evaluates pre-analytical, analytical specimen integrity. This is one way we can know if a sample is contaminated. The mean cell or mean corpuscular value is found by taking the known hematocrit, dividing it by the red blood cell count, multiplying it by 10. The reference range is 80 to 100 femtoliters, and this implies a red cell that has a size of 6 to 8 microns. If you haven't used a microscope yet, the 6 to 8 microns doesn't make much sense to you yet, but it will. So the reference range, the normal range for MCV is 80 to 100 femtoliters. So what does the MCV mean? What does it indicate to you as a student? A shift in MCV can be caused by cold agglutinates, which means your MCV will be increased falsely. So that 80 to 100, your MCV can be 105, which looks like a macrocytic anemia. The shift in MCV can be caused by transfusion therapy. So in that case, a patient has received red blood cells that are now from a donor. Right? So they're not really your normal population. In essence, you have more than one population of cells, and then the MCV can change in that sense. A shift in MCV can also be caused by reticulocytosis, which is increase in reticulocytes. Increase in reticulocytes is going to throw off the count that is done by the analyzer. If you have an increase in reticulocytes, you're going to actually have to look at the slide and determine if the MCV is correct or not. There can be a pre-analytical change in MCV caused by contamination drawn through IV lines or indwelling catheters. So this is going to falsely decrease our MCV. Specimens from hyperglycemic patients. So hyperglycemia is increased blood sugar, so diabetic patients, and some patients on chemotherapy drugs. MCH and MCHC. Mean corpuscular hemoglobin is MCH, and mean corpuscular hemoglobin content is MCHC. They provide information concerning the red blood cell hemoglobinization. So this is specific to the hemoglobin. The MCH is the hemoglobin divided by the red blood cell count times 10. So mean is the average. This is called the average weight of hemoglobin, and the reference range is 27 to 29. MCHC is you take the hemoglobin divided by the hematocrit, multiply it by 100, and this becomes the average amount of hemoglobin per red blood cell expressed as a percentage. The reference range is 32 to 36. I cannot stress to you how important all of this is, this being able to perform these calculations, because you will have this on an exam. I can almost guarantee it. You're going to have a calculation of related to these indices on your exam. Thus far, everyone has. That being said, this slide you should print out, or you should save it if you're into the digital format, and look at key equations. The mean cell volume, mean corpuscular volume, hematocrit divided by red blood cell times 10. Mean corpuscular hemoglobin, mean cell hemoglobin. Hemoglobin, see, because notice hemoglobin is in the term. Hemoglobin divided by red blood cell count times 10. Mean corpuscular hemoglobin content, again, hemoglobin divided by hematocrit times 100. So my trick for remembering this is that if it has the word hemoglobin in it, then hemoglobin should be on top in your equation. And then everything else is hematocrit. So the mean cell hemoglobin, red blood cells times 10, mean cell hemoglobin concentration, hemoglobin hematocrit times 100. And then the correlation check. You start with the hemoglobin, times 3 equals the hematocrit, plus or minus 3, or you take the red blood cell times 3 and you get the hemoglobin. So I would advise you to commit this to memory. It is that important. Red cell distribution width, it's a calculation, and it basically is telling you the size of the red blood cells that have been distributed within that sample. So it gives an insight into what's called anisocytosis, which means variation in size, and poikilocytosis, which means variation in shape in a blood smear. If you have not taken my intro course where I showed you how to understand what terms like this mean, I advise you to take my intro course. So aniso is size and poikilo is shape. Cytosis is cell, the CYTO, and osis part means increase or change. So if you have not taken that course with me, it would be a good idea for you to take it just to help you understand terminology. All right, so the RDW is the standard deviation or red blood cell volume divided by the mean, which MCV multiplied by 100. Reference range 11.5 to 14.5. Most of the time you don't have to calculate this on an exam, but you do kind of need to know what the range is. Platelet count is also included in the CBC. All right, so critical values. What are critical values? They are values which fall outside of the reference range, which indicate a potentially life-threatening situation. These values must be called to a provider within a certain time. Right now, for the laboratory, we have to call, well, at a lot of places, you have to call the critical values within an hour, but mainly within 30 minutes for, say, a troponin, which indicates they're having a heart attack. And so say I have to call the critical value within 30 minutes to the nurse, then the nurse has 30 minutes to call it to the doctor so that the doctor can act on it within that hour time frame. Proper documentation of the notification of the critical value has to be done. All right, here are its reference ranges. Taking account that these ranges are kind of standard, but they vary, and they vary depending on where you are. If you're in California, if you're in Europe. So this is like a standard in the United States. Your white blood cell count, the ranges are always divided into what's good for children, newborn, then what's good for an adult male and female. For an adult male or female, that's normally a person greater than 18 years of age. You can find ranges broken down into other ways, like they can break it down for a child that's 2 years old. What you need to know is standard, what is normal. So here's some ranges. I won't go through all of them, but I want to point out a few things. There are some variations from newborn to the adult side. Starting with white blood cells. Newborns who have just arrived into the world can have a really high white blood cell count, and that's okay. Their body is changing and they're coming into a place where there's all kinds of attacks on the system, so that's fine. The hemoglobin can be higher. They just got here. They have a lot of immature cells. The hematocrit can be higher. The mean cell volume can be higher. The MCH can be higher. So in essence, newborns their ranges don't necessarily match adult ranges. The red cell distribution with the range 11.5 to 14.5 is standard no matter what. And the platelet count of 150 to 450 is standard no matter what. This next slide is just for some of my international students to make sure you understand what the information I just gave you on the previous page looks like when you convert it to international units. So what happens when a person has anemia? Well, anemia, decrease in oxygen capacity. The hemoglobin is going to be seen as below 7. And then you get symptoms. Vertigo, dizziness, pallor, meaning their skin changes color, fatigue, they're tired, tachycardia, and syncope. So their heart is not beating as fast, and then they feel like they're going to faint. So reticulocytes are red blood cells that no longer have the nucleus, but they have not reached full level of maturity. We use a right stain to see them. The reticulocytes are seen as polychromatophilic, so they're kind of a bluish color. And they are macrocytes, means they're large. Most effective way to assess the red cell production and response to anemia. If you see reticulocytes, that means the bone marrow is trying to compensate for the anemia. They are counted using new methylene blue or brilliant crescent blue stains. Later on, you will actually have a lesson about reticulocytes that would be in more detail. Normal adult count is 0.5 to 2.0. Newborn count is 2 to 6.0. Newborn count is higher again because the baby just got here. Bone marrow is not as effective. Decrease in reticulocytes represent ineffective erythropoiesis. So if you have a normal count that's 0.5 and then you get a patient come in and they have a 0.2, that lets you know that there's a problem in the production of red blood cells, and that could be a problem with the bone marrow. Increased reticulocytes indicate rapid red cell turnover. Of course, these are going to be indicative of types of diseases that are present. And there's going to be more to come in our future discussions.